Good evening, everyone, and welcome to our webinar, which is the second event in a four-part series exploring the topic of adapting to a neurodiversity affirmative paradigm in child and adolescent services. My name is Tara O'Donnell-Killen. I'm the founder of Thriving Autistic, and I will be your chair tonight. So first, some housekeeping. The event tonight is brought to you as part of a joint initiative by Thriving Autistic, the Children's Clinic, the Adult Autism Practice, Childversity, and the HSE in collaboration with the Autism Special Interest Group of the Psychological Society of Ireland. You can submit your questions and comments through the Q&A button on the bottom of your screen. And at the end of the presentations, we will be holding a live panel discussion with our contributors, and we will try to get as many of your questions answered. But please do try to get them in throughout the presentation. We are not going to be able to respond to anybody who may raise their hands, so please do make sure you make use of the Q&A function instead. Feel free to get up and take movement breaks as and when you need them. Remember, this is a webinar, so nobody can see you or hear you. If you are tweeting, please use the hashtag NeuroAffirmativeWebinars and make sure that you tag PSI Autism SIG. If you require CPD points from the PSI, please email autism@psychologicalsociety.ie after this event. We will do our absolute best tonight to keep to time, and hopefully it will all run as smoothly as possible. Can I remind you though, please don't share your attendee link with anybody else because this event is completely booked out. Sharing your link could mean that someone who has already registered won't be able to join in. We are recording the event and it will be made available publicly online. And it's also available right now on Facebook as a live stream. Please pre-register at the Psychological Society of Ireland website for the rest of the webinars in our series. They're taking place on Wednesdays at 8 for the next 2 weeks, and details are on the website. Also, we will be holding a workshop for psychologists on neurodiversity affirmative adult autism assessments at this year's PSI annual conference on Wednesday, the 10th of November. And by the way, many of us are involved in writing the Neurodiversity Affirmative Adult Autism Assessment Handbook, which will be coming soon. Okay, we're moving on to contents and we're almost finished with the housekeeping. I'm going to be shortly giving a really brief introduction to tonight's presentation by the Carlow Kilkenny team, which will then be followed by Maureen's perspective. Maureen is a parent who is engaged with the services, and then we will have the Q&A. Okay, housekeeping is out of the way, so we're just about ready to start. I hope that you are all sitting comfortably, have had your food, have something to drink, have a piece of pen and paper if you need to take notes, and let's get started. So tonight I have the pleasure of introducing you all to the Carlow Kilkenny HSE Child and Youth Disability Team, and Maureen, a parent whose family has been positively impacted by the work that they do. It's really rare to have the privilege to gain a glimpse into a change process as it's actually happening. But tonight, we're all going to be gifted with insights from this small team of deeply committed professionals who are working together to cultivate positive change from the bottom up. Now, as we're all aware, the institutions and the structures themselves need radical overhaul to become aligned with the human rights model. Waiting lists are extremely long. None of us tonight are saying that the systems themselves are neurodiversity affirmative. We've all been handed down these institutions, which were built upon a false belief system that there is just one gold standard shining example of being human, and that everyone else is less than or other and needs to be changed to fit into society. What we are attempting to do, though, tonight is to inspire you to take action, to change your own processes, your own service provision, and your own workplaces by showing you what is possible when you work together within the neurodiversity model to create positive change. In the words of the great Barack Obama, change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. And now I'm going to hand over to the Carlow Kilkenny team, who will describe their experience of working towards being those agents of change. Thank you.
Hi, many thanks to everyone for attending tonight. We are really looking forward to discussing our experience in adapting to a neuroaffirmative paradigm in our work. In our presentation, we'll be looking at the following areas: the who, what, why, and how have our change to neuroaffirmative practice, what hasn't changed but has worked well, challenges encountered, next steps, and reflections on our practice. In this webinar, we'll be exploring the ways in which we have changed our practice with respect to our understanding of neurodivergence and with particular reference to autism, as this is our primary area of our work. I will start by introducing myself and my colleagues. My name is Bernie Gagan, and I am a social worker with the CDNT team for the last 6 years. My role in the team is to support families at times of crisis, but also, if needed, support them through their engagement with our service. Often this means that I am the first member of the team to meet a family, and over the last number of months, I have made active efforts to use a neuroaffirmative approach in this discussion rather than pathologizing one. Orla Short is a speech and language therapist working in this service since 2018. Orla is relatively new to autism assessments, and her experience in diagnostic assessments to date has been primarily using a neuroaffirmative approach. On reflection, she feels that her previous SLT clinical practice was more aligned to a medical model, and over the last number of months, she has made changes to her practice to bring it in line with the neuroaffirmative approach. Karen Coleman is a speech and language therapist who has worked in HSC disability services in Carlow for nearly 4 years. When Karen first started working, she was primarily using a medical model of disability as per her training. However, over the past few months, Karen has attended various autistic-led trainings and is now trying to implement a neuroaffirmative approach to her clinical work. Having worked in the medical model previously, it is now clear to Karen how important it is to align practices to a neuroaffirmative approach and to recognise the needs and wants of the community that we are serving. Aoife Dorn is an occupational therapist working with the CDNT team in Carlow since 2019. Aoife works with autistic and neurodiverse children and young people, as well as their families in her role. Aoife was not directly involved in the autism diagnostic assessment process. However, many of the children she works with have either been through the process or undergoing assessment or awaiting assessment. And in this regard, Aoife would liaise with the diagnostic team. Aoife has always strived to work from a strengths-based perspective. However, it is in recent times that she has gained a greater understanding of what this really means in terms of applying a neuroaffirmative lens to practice. Suzanne Wall is a psychologist working with the HSC Disability Services in Carlow for the last 6 years. One of the primary areas of Suzanne's work over this time has been in autism diagnostic assessments, and this is an area of her practice which has undergone significant change over the last number of months as she has tried to implement a more autism affirmative approach in her work. We all work in the Carlow Kilkenny Children's Disability Service, where we provide services to autistic and otherwise neurodivergent children and young people and their families. Our service has very recently progressed from a multidisciplinary to an interdisciplinary team under PDS, which will signal a move to greater team understanding, which we are very much looking forward to. We are 5 clinicians based in this service who have adopted a neuroaffirmative approach. Many of our colleagues have also engaged in autistic-led CPD. However, we are conscious that we do not speak for everyone, nor do we represent the entire Carlow Kilkenny team. Our focus in tonight's webinar is on changes we have made individually and as a small team. Over the last number of months, we have made conscious changes to our practice and are actively implementing a neurodiversity affirmative approach to our work. However, this is an evolving process. We are constantly reflecting on our practice, evaluating and modifying this according to the views and wishes of the autistic and neurodivergent young children and young people who we work alongside. With that in mind, it is important for us to acknowledge that we feel that adapting to a neurodiversity affirmative paradigm is a journey, and we are very much at that start of that journey. Up until approximately 6 months ago, we tended to use a medical model of disability in terms of our understanding of autism and other disabilities. With regard to the language we used, the assessment process, the support provided, and the information given to parents, schools, etc. Our understanding of autism and disabilities was based on what was taught in college and professional training we previously attended. We assumed that expertise lay with clinicians and the neurotypical academic community. This then informed the language we used, which featured terms like ASD or person with autism. Up until quite recently, we typically used a normative approach towards the identification of autism and our subsequent recommendations for a child or young person. Our reports are written with other agencies in mind. Often this required that we presented a worst case scenario in which we placed the greatest emphasis on a child or young person's areas of need in order to access the greatest supports. This was done with the child and family's best interests in mind. Unfortunately, this can sometimes still be required, for example, when facilitating parents to access appropriate supports from the Department of Social Welfare. Under this model, we are promoting neurotypical goals with regard to a number of different areas, including communication, social interaction, sensory processing, and behaviour. Our interventions are focused on neurotypical expectations around eye contact, turn taking, sharing, group play, topic maintenance, topic change, small talk, speaking, behaviour, etc. Through reflecting on our practice, it appeared as though our approach was not fully meeting the needs of children and young people attending our service. It was not validating their experiences, nor was it recognising their full potential. At the same time, we became increasingly aware of the neurodiversity movement through our interactions with colleagues, parents, and social media. This in turn encouraged us to actively seek out further information from the autistic community, which then led us to formal autistic-led CPD. Twitter has been one of the primary social media platforms where we have found information from the autistic community, following threads and hashtags such as asking autistic and actually autistic. This then led us to further research and trainings, which were informed by Autistic Voices or autistic-led, such as The Inside of Autism with Kieran Rose. Engaging with the CPD in a reflective manner highlighted the need for a change in our understanding of disability, as the medical model was not meeting our needs, the services needs, and most importantly, the needs of children and young people who attend our service and their families. This led us to working in a different way. I will now pass you over to my colleague, Suzanne Wall.
We are now no longer working using the medical model of disability insofar as we can, and instead are now using the social model of disability. The social model recognises the disabling impact of social and environmental barriers, which need to be tackled if a person is to achieve their potential and live an authentic life. The teachings of the neurodiversity movement are at the core of our approach. We now recognise that the best and most relevant source of information in relation to autism and neurodivergence is the autistic and neurodivergent communities. This has had a significant impact on the language we use, how we introduce, structure and discuss assessments and outcomes, the goals of subsequent interventions and the universal supports that we provide. The neurodiversity movement champions the viewpoint that brain differences or different neurotypes are valid and needed, rather than being seen as deficits. It also states that neurodivergent people experience, interact with and interpret the world in unique ways. Looking through this lens has reframed the way in which we think about autism and neurodivergence, and how much we need to look at the environment, society, and the prevailing narrative. We deepened our understanding of autism and learned about associated characteristics and autistic-led theories, such as Milton's double empathy problem, differences in sensory processing, and particularly those which we would have been less familiar with, such as interception, face blindness, and valuing differences in communication. All of this has informed how we reflect on our work and how we shape our current practice. Through all of our interactions with children and young people, we presume competence. We recognise that limits cannot and should not be inferred onto children based on their ability to produce speech. We also consider the sensory processing differences, which may impact their ability to participate in any given context. And we recognise that in times of stress and overwhelm, the capacity to understand language will diminish. Presuming competence includes the inherent capacity to think, understand, and learn. The challenge which we need to take on as therapists is to find the right supports and systems across all domains to help children be successful and participate in those activities which are meaningful to them. Our current understanding has highlighted the challenges of being neurodivergent in a neurotypical world and the impact of masking on the well-being of neurodivergent children and young people. As a result, we are now more aware of this and not recommending neurotypical expectations in our practice. Our new understanding has led to a change in our language. We evaluated the language we used previously, which had been taken from the official diagnostic manual and recognised assessment tools. And looking at it through this new neuroaffirmative lens, we realised that it was not fit for purpose. We are now actively trying to change our language. We have moved away from terms such as deficit, difficulties, atypical, abnormalities, and nonverbal towards more neuroaffirmative terms such as differences, preferences, characteristics, experiences, non-speaking, etc. This is an ongoing process as we constantly check our language and evaluate this to ensure that it is in line with our understanding of neurodivergence. For example, we are currently having team discussions regarding the appropriateness of commonly used terms such as intervention and feedback. From listening to autistic voices, we know that most autistic people consider autism to be a part of all aspects of their identity. And so, to be respectful of the autistic community's preferences, we use identity-first language. When working with a young person, we check to see what their preference is with regard to language and if they prefer person-first or identity-first language. In terms of assessment, our focus has shifted from comparison to the neurotypical population to developing an understanding of how a child or young person experiences and interacts with their environment and world. From the initial contact with the family at the start of the autism assessment process, we introduced the concept of autism in line with our current understanding, namely that it is a different neurotype. Introducing autism in this way creates an environment for parents to learn about autism as not being a big scary thing that is happening to their child. The language we use as professionals here at the start is really important, and parents who are new to this will adopt the tone we take. If, for example, we say, "Tell us about your concerns for your child," this sets a particular tone. If, however, we say, "Tell me about your child's interests and how they spend their time," this sets a completely different tone. At this time, we also discuss some of the strengths that autistic people can have and some of the challenges they face from functioning in a society and a world that is not designed for them. When corresponding with families, we aim to offer information in both verbal and visual format, depending on what parents would prefer. We send a picture of the building and the individual therapist in a letter, as well as sending a list of questions for older children, which gives them the option of writing their answers prior to coming to clinic. We are cognizant of the fact that many parents of autistic children and young people are likely to be autistic themselves and will have their own preferences for how they best communicate and interact with others. We therefore ask parents how they would like to communicate with us in order to carry out the assessments, and we tailor appointments to suit their preferences. For example, the parent interview or the ADIOR is offered in a face-to-face format, via remote means, or over the telephone, according to parental preference. We have made changes to how we undertake an assessment. We begin by making environmental changes to clinic spaces. When preparing a room for an assessment, we remove busy visual information and try to ensure a quiet space. During the assessment, we attempt to accommodate an individual's preferences. So, for example, providing breaks, asking if they would like to move or stand or explore different seating positions, asking about eye contact preferences and modifying ours accordingly, as well as asking if they would like to bring in any item that they find calming. So, for example, stim toys, fidgets, teddies, and so on. We try to use less language, a reduced pace, more concrete language, and allow for more time for processing of information. We also aim to use a total communication approach, supporting our verbal language with gestures, real objects, visuals, and demonstrations of tasks, insofar as this is possible, the aim of which is to create a safe space and reduce stress. In terms of SLT assessments, we have moved away from comparing social communication and non-verbal communication to neurotypical expectations. For example, instead of comparative descriptors such as reduced or lack of, we use language that validates autistic communication styles. So, for example, using terms such as preference for object-oriented eye gaze. Terms such as one-sided have been replaced with descriptive language such as They enjoyed talking about specific topics of interest. We also ensured that we clearly state when we are comparing to the neurotypical population, so when using scores from standardized assessments. The descriptive classifications used in assessment tools are deficit-based. And as a result, we tend to avoid using them and report the same scores using neuroaffirmative language. We also use alternative measures in place of some standardized measures. For example, we are now using a neuroaffirmative communication checklist designed by Emily Lees, Autistic SLT. We also use a neuroaffirmative approach during feedback from autism assessment to parents, which means that we reaffirm that autism is a different but equally valid neurotype that is part of human diversity. Out of respect for parents' communication preferences, we also offer the option for communication about the outcome of an assessment to happen in many different formats, depending on an individual's preferred way of communication. So, for example, in written format, communicating verbally, remotely, by phone, and so on. This is reflected in our written reports, in which we have reframed core characteristics. And a key question that we try to ask ourselves while writing reports is, am I being mindful that the autistic person will read this report, and how will they feel about themselves? Here we have an example of how we have reframed and adapted our report writing. We continue to use the DSM-5 criteria in the identification of autism, as this is in line with current best practice guidelines. However, we are aware that the criteria are deficit-based and therefore out of date, and the current best practice guidelines have not yet caught up with current thinking in relation to autism. Therefore, we continue to use the DSM-5 criteria in terms of the different areas associated with autism, but we have reframed how we interpret and explore these. The following are examples of these. So, deficits in social emotional reciprocity has been reframed as experiences of social and emotional reciprocity, including individual preferences for how a child or young person likes to communicate and interact. Deficits in nonverbal communicative behaviours have been reframed as experiences or differences in nonverbal communicative behaviours used for social interaction. Deficits in developing, maintaining and understanding relationships have been reframed as experiences of developing, maintaining and understanding relationships. Stereotyped or repetitive motor movements, use of objects or speech, is now been reconsidered as particular motor movements, particular use of objects or particular speech. Insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or non-verbal behavior has been reframed as preference for sameness, particular routines or particular patterns of behavior. Highly restricted, fixated interests that are abnormal in intensity or focus is now been reconsidered as particular hobbies, passions and interests. And finally, hyper or hypo-reactivity to sensory input or unusual interests in sensory aspects of the environment has been reframed as hyper or hypo-reactivity to sensory input or particular interest and enjoyment in sensory aspects of the environment. And now I'm going to hand you over to my colleague Karen, who's going to explore some of these examples in further detail.
On the screen, we have specific examples of reframing under each criteria of the DSM-5. We have used a hypothetical example of a young person named Tim. Under social emotional reciprocity, we would have previously said, Tim demonstrates a lack of reciprocity in his interactions. However, we now say, Tim enjoys talking about areas of interest and speaks about Star Wars enthusiastically. He prefers to engage in conversations related to his topics of interest. Under nonverbal communication, before we would have said, Tim presents with reduced eye contact. Now we say that Tim tends to use object or task-oriented eye gaze. He noted that he finds eye contact uncomfortable and it is easier to communicate with others without using eye gaze. Before, we would have said that Tim has deficits in nonverbal communication. Now we say that Tim presents with differences in his nonverbal communication. Before, we would have said that he does not use gestures to support his verbal communication. We now say that Tim does not shake or nod his head. He prefers to use verbal communication to indicate yes or no. In terms of experience of relationships, we would have previously said that Tim has difficulty making friends. Tim engages in repetitive play sequences. We would now reframe this to Tim presents as content to play alone and prefers to engage in similar play patterns. He enjoys very detailed play around his own interests. Before, we would have said that Tim appears to be on his own agenda. We would now say that Tim demonstrates a lovely ability to focus on activities of interest. Finally, under particular movements, we would have said that Tim was observed to flap his hands repetitively. Now we reframe this to Tim finds moving his hands calming, or Tim was observed to move his wrists when excited. With regard to preference for sameness, Tim is restricted in his daily routines and has difficulty coping with change. Whereas now we would reframe this to Tim stated that he has a preference for routine. In terms of particular interests, before we would have said Tim has very restricted and prescribed interests, for example, Star Wars. Whereas now we would reframe this to Tim has a keen interest in Star Wars, demonstrating a wonderful knowledge of this. Under sensory experiences, we would have previously said Tim demonstrates sensory processing dysfunction in relation to his visual processing and body movements. We would have said Tim presents with sensory processing difficulties. We now reframe this to Tim demonstrates some sensory preferences and differences in terms of his visual and touch processing. Tim uses movement to help self-regulate. He is energetic and derives great enjoyment from visual objects. Before, an assessment for autism compared a child to how well they did or did not perform as a neurotypical. How good were they at being neurotypical, or how deficient were they? Now we are exploring how much of a child's experiences align with the autistic experiences of others. This is a much more validating experience for children and young people, and as well their families. Throughout the assessment process, we are trying to understand the child or young person holistically and understand their strengths, neutral characteristics, and needs within society and environments. This is done along with recognizing the challenges a child or young person experiences. In our interventions, we are trying to address challenges which a child or young person is experiencing by addressing the barriers within their environment. We try to identify ways to make adaptations to accommodate their needs and to establish the supports required to thrive and grow through their own authentic neurotype. This can often involve looking at the sensory, communication, and social demands in the environment and seeing how we can adapt these to suit the child or young person. We try to ensure that we are not undertaking interventions which explicitly or implicitly try to change the individual, nor do we look to make adaptations to their behavior so that they appear more like a neurotypical person or less autistic. This process is in its relative infancy, and while this is our aim, we acknowledge that we might not always get it right. It is an area which we reflect upon regularly and we collaborate with parents and children on. Within SLT interventions, we have made a significant change with respect to what we would have called social skills training. We now recognize that this is based on neurotypical social skills and it is not appropriate. It is clear from listening to autistic people and from the research undertaken in this area that teaching neurotypical social skills to autistic children is harmful to them as it increases masking, which we know severely impacts negatively on mental health. We do not want to contribute to masking, and we ensure that our goals are now not based on neurotypical expectations. For example, eye contact, turn taking in conversations, topic change or topic maintenance. Instead, we are currently in the process of devising a new training which focuses on promoting self-advocacy, understanding the double empathy problem, understanding monotropism, and providing opportunities for monologuing, using a total communication approach and other supportive communication strategies. We also share general information and information leaflets relating to autism and neurodivergence with teachers, so as to promote greater shared understanding. From an OT perspective, there has been a new focus on stimming and educating parents and schools in relation to this. Previously, the focus might have been on reducing or getting rid of stimming behaviours. However, the focus has now changed to understanding the purpose of these and creating opportunities for stimming and self-regulatory behaviours. From a psychology perspective, attending autistic-led training has led to an increased awareness of the co-occurrence rates of autism and trauma and burnout. We have learned about the importance of understanding difficulties such as school refusal and challenging behaviours through a neurodiversity lens. This has shifted the focus from a behavioural approach to placing focus on developing understanding of autism and how to meet an individual's needs and preferences, how best to support emotional regulation and environmental changes, and to cultivate an autistic identity that is valid and authentic. In summary, when devising interventions, we strive to develop goals collaboratively with the parent and child or young person. We do not introduce goals that focus on suppressing or masking autistic traits, as this would negatively impact the child or young person's well-being. For example, reducing or eliminating self-regulatory behaviours, increasing eye contact. Rather, we validate their experiences and strive to identify goals to support the person to achieve their full potential within their environments. We acknowledge that challenges arise not from a child or young person, but from the mismatch between the child's preferences and their environment, example, school. I will now hand you over to my colleague, Orla.
This approach is mirrored in the information we provide to parents, schools, and others who work with a child and young person. We have redesigned our workshops and webinars, as well as our information leaflets, to reflect this neuroaffirmative approach, so that more people working with a child or young person, and indeed the young person themselves, have a shared understanding of autism and neurodivergence, the strengths associated with this, and how to advocate for the most appropriate supports needed for an individual to achieve their potential. This includes signposting to relevant information and resources informed by the autistic and neurodivergent community, where children and their families can find a space to celebrate and embrace differences, to help them form a positive autistic and neurodivergent identity, and not one which is negatively biased by a pathologizing narrative. What hasn't changed? So the referral pathway into our service is still the same. Our assessment tools have not changed. We still continue to use the ADOS, the ADIR, the CARS, various formal cognitive and language assessment tools. However, we now understand that there are significant limitations to the instruments, such as the ADOS, the ADIR, and the CARS. These tools are all designed to compare autistic children to a gold standard neurotypical child, and the language used within these tools is significantly deficit-based. Through developing our understanding of this, we have come to report on these measures in a different way. We have moved away from the descriptors and language used and have instead reframed this. We also continue to abide by the DSM-5 criteria in terms of the identification of autism, and we ensure that the child or young person's experiences are explored in detail to determine if they align to that of an autistic experience. Our service continues to take a child and family-centred approach, looking at each child and family individually and providing bespoke interventions and supports. Every child or young person still accesses the same supports within our service, and overall, all elements have remained the same, but we have modified each aspect to be in line with our neurodiversity affirmative paradigm. A number of different positive factors have contributed to the success of this change. The first of these is that a group of clinicians took this step forward together. We attended trainings, shared useful resources, and used a collaborative approach in our practice. It was beneficial to take this step together, as this helped us to reflect safely on our previous practice and to guide each other through this. This led to healthy discussions about our language, goals, and approaches through which we were able to learn together. We were also very lucky, as there was an openness to change amongst the wider team, strong relationships between clinicians, and a lovely ability to self-reflect together. We were also very fortunate to have the support of our individual clinical managers, Dr. Lorraine Seary, Maeve Cleary, Regina Doyle, and Yvonne Power, as well as our new CDNMs in Carlo Kilkenny, Dervla Hunt, Marguerite Minogue, and Thérèse Healy. We are so grateful that they welcomed our engagement in further learning and allowed us the clinical time to attend these trainings and create new neuroaffirmative processes, without which this change could not have been facilitated. Most importantly, the response from our primary stakeholders, the children and young people we work with and their families, has been positive, and this has given us the motivation to continue on this journey. A challenge that we have experienced at times is around parental expectations in relation to their child's communication, behaviour, and validating the child's experiences. However, from listening to and acknowledging the parents' experiences and emotions, it's clear that these expectations and desires are with the child's best interest at heart. For example, wanting a child to reduce certain stimming behaviours so that the child is not mocked in school, or wanting to increase eye contact so that they are accepted more readily by peers. It is understandable that parents feel this way. However, it is also important to work with them to gently support their understanding that trying to change their child to fit with neurotypical expectations is going to be more harmful for their child and not in their best interests. Cultivating their autistic identity and focusing on and developing their strengths is going to be much more beneficial. We feel that there will be a limited impact of change until all stakeholders, so schools and other agencies, have a shared and more current understanding of autism, which is why webinars and events such as these are so important. It has been difficult moving away from language which has been ingrained in us since college or training, and this is definitely an ongoing challenge, and we frequently correct ourselves on this. We are in a change process, and as it was said at the start, we are not presenting the perfect model. We are constantly evaluating ourselves and seeing where we can go next and what needs to be adapted. Some of our next steps going forward include the following. So we will try to be even more accommodating and respectful of families' communication preferences. So modifying appointments and correspondence to facilitate all communication preferences. For example, offering appointments by phone call or by letter. We also hope to have videos of staff introducing themselves available, which will support children and young people attending our service. We will continue to modify all handouts and tip sheets that we provide to families or schools. We also hope to create neuroaffirmative workshops, webinars to support the needs of children and young people in our service. We hope to promote a neuroaffirmative way of working within the wider service, for example, in adult services and also in primary care. Similarly, we hope to promote a neuroaffirmative way of working with other agencies. We hope to establish a pathway for getting feedback from families following the assessment process. We hope to receive feedback from a representative of the autistic community around our reports, our language use, the assessment process, and so on. And an application for funding has been submitted for this. In future, we hope to provide webinars for school staff and pupils to further their understanding of autism, while we can support the autistic child or young person to better understand the how and why of neurotypical social skills. We also need to educate their neurotypical communication partners on the how and why of autistic communication. By doing this, we are validating all communication preferences and styles and working towards reducing the double empathy problem. We hope that the HSE recruitment process will be more accessible to neurodivergent people and that this will lead to more neurodivergent professionals within the team. We will continue to examine our intervention approaches and ensure that we are listening to the autistic voices around these. We are aware of the autistic community's experiences with certain approaches and the negative experience that they have documented. And we are now looking at our supports and trying to eliminate certain elements. I will now pass you over to my colleague Aoife.
As this has been a recent change in the last 6 months, we have not yet received systemic feedback from clinicians and families. This picture is emerging as we are still evolving as a team and continually make changes where we need to. We continue to evaluate our practice and the language we use, primarily through conversations with each other based on what we have read or heard that day. Many of our colleagues are interested and have asked questions about upcoming training or language use. We have found that all disciplines consider it relevant to their work and have asked us where they can find autistic voices and further information on neurodiversity and the neuroaffirmative paradigm. We also found that parents have been very receptive to this way of working. We have an interview later from a parent of 2 autistic children in our service who will give an account of their experience of using a neuroaffirmative approach. From speaking with some parents following assessment or intervention, there is a clear disappointment that these views have not yet been accepted by the wider community and other agencies. Moving to a neuroaffirmative way of working has been a huge change process for all of us, particularly amongst the reconfiguration to PDS. Our biggest change was the shift from listening to experts, lecturers, researchers to listening to autistic voices. We have realized that it is okay to say that this is what we previously thought, but this is what we know now. It was challenging to consider how to introduce this concept with parents who were familiar with our previous model of understanding autism. However, parents did not find this difficult and accepted that the language we used previously was based on a knowledge at that time, but is now outdated and not reflective of the autistic community's preferences. Using descriptors for development is difficult as we do not yet know enough about autistic development. For example, describing milestones or language. Can we truly comment on whether these skills are delayed when we are only comparing to neurotypical development? Further research with the autistic community and led by the autistic community is warranted to increase our understanding of autistic development. There are still many elements of our work that we continue to reflect on and think about. For example, some of the language we still use. At the minute, we're looking at the word feedback following an assessment. We are thinking that the word feedback can seem very medical, with the clinicians giving the diagnosis, when we have just worked collaboratively with parents and older children in reaching this conclusion. Also, as we mentioned earlier, the word intervention. What are we intervening for? Is supports a more appropriate word? One aspect that we have found very difficult during this period is the mismatch between services. It's difficult to bring a family through a neuroaffirmative autism assessment when we then have to ask them to be deficit focused when trying to access supports from other agencies such as the DCA. Similarly, it is difficult to set the tone of neuroaffirmation from the start when many of the national documents around progressing disability services are written with the deficit-based language as well as inappropriate language such as ASD. Lastly, we have found that it can be difficult and uncomfortable process at times to reflect on your work. There were feelings of shame and embarrassment when thinking back to certain aspects, such as teaching neurotypical social skills. We found that we were sometimes uncomfortable during certain trainings and during conversations and reflections we did together. For example, looking at old reports and recommendations. We found ourselves to be somewhat defensive at times, so we had always been child-centered. However, our knowledge was coming from the wrong source, that is, not the autistic community. As part of this process, we are trying not to be too hard on ourselves and acknowledge that we are not presenting a perfect model of neuroaffirmative practice. However, we will continue to try to change and we will continue to learn from the autistic community. Here are some of our colleagues' reflections and learning points about moving to a neuroaffirmative way of working. Sarah Kearns, educational psychologist with the Carlow CDNT, shared with us the following. Working within a neurodiverse affirmative paradigm has shifted the emphasis on neurodiversity as a natural form of human diversity. It promotes identification and acknowledges preferences and experiences. It is a language of acceptance and difference. Our neurodiverse affirmative assessment process and report writing aims to support a shift in how neurodivergent people are viewed and understood in the home, school, workplace, and community. I have become increasingly mindful that one day this child will be a young person or adult who may read their assessment report. As a professional, I would hope that our work will have helped positively shape identity and how that person sees themselves and their value in the world. Senior OT Irene Kenny with Carlow CDNT shared, for so many years, the focus was on diverting stimming behaviour, whereas now we understand that stimming can serve a real purpose for some autistic people, for example, to help regulation. Clodagh Power, senior psychologist with Kilkenny CDNT shared, I became increasingly aware of the importance of placing due emphasis on an individual's lived experience, the importance of making environmental changes and the changes needed in the second level school system to help an autistic young person to feel safe and secure. This includes the need to increase awareness amongst teachers about autism and masking and the negative consequences of this, but also how different outcomes can be achieved through increasing this awareness. Lindsay Noble, Senior SLT with Carlow CDNT, shared with us, For years, I have worked differently, forcing eye contact, going against a child's lead, prescriptive programs, negative consequences, etc., has never felt right to me. This has been a challenge in a very traditional system, a system that values quantity over quality, and it has proved to be quite isolating from a personal and professional perspective. I feel such relief that the tides are finally turning and that there is finally a truer understanding of the strengths, needs, and magic to be found within neurodiversity. Finally, the system is listening. Regina Mullins, social worker here in Carlow CD&T, shared, in terms of truly taking on a neuroaffirmative way of working with children and young people with autism, we come from the idea that it is not how the children suit or fit into already established environments of school, college, sporting clubs, and other social environments. We start from the perspective that the child comes first. Differences are natural, and any place or intervention a child needs takes on this positive approach, enabling development through diversity. We have a reflection from a teacher who shared the following. I was a mainstream teacher for the past 13 years and have only this year moved to SET. Throughout my years in mainstream, I have had autistic children in my class, and if I am to be completely honest, I was always very unsure of how best to facilitate their needs. I felt as if the information that I would look up and have access to was quite varied and sometimes even contradictory to what I was experiencing in my own classroom. I always felt a bit lost as to what was the best thing to do in certain situations involving autistic children in my class. I have been hearing more about autism and neurodiversity in recent years, but it was really only in the past few weeks after a conversation with a speech and language therapist that my attention was really drawn to what it means. Having read through the information that I was sent regarding this, I have to say that I am so glad that I have access to this information and the research that has been done. Now that I am working in SET, I will have more one-on-one time with autistic children. While previously this would have terrified me in a way, I now feel more competent and confident in this area. I still have so much to learn, but I am very glad that I am on this side of all the research. When I started teaching 14 years ago, this was a really grey area, and I am very glad for the sake of every autistic child that I will encounter in the future that we have access to this research and can be more informed about autistic differences and preferences. Autistic-led and/or neuroaffirmative training has been invaluable to our team. Here are some trainings that we have found to be very informative. Inside of Autism by Kieran Rose, Autistic Communication by Owen Stevens, Autism and the Social World by Evelyn Welton, Empowering Autistic Women and Girls with Nikki Collins, Valuing Neurodiversity in SLT Practice with Elaine McGreevy, Embracing Autistic Children with Awesome Ireland, upcoming training with Elaine McGreevy and Emily Lees. Over the next few slides, we have listed resources that you can look back over in your own time. Many thanks for listening to our presentation today. We hope we have highlighted the importance of moving towards a neuroaffirmative approach and how meaningful it has been for ourselves and the families that we work with.
Well, wow, that was absolutely stellar presentation by the team. Thank you all so very much. And just a reminder to everybody that we're going to have the Q&A very soon with the panel, with all of the team who are at the recording there. And now we're going to hear from Maureen. And Maureen is a parent who has access services with this team, and she has recorded a short presentation. There are a couple of technical syncing issues at the very beginning of this recording, but they do smooth out. So please bear with us. And it's quite a short video, and then we'll move into the Q&A. Thank you.
Hi, Maureen, how are you?
Hi, how are you?
Good, thanks. I just wanted to start off by saying thanks so much for taking part in this. And I suppose to jump right in, would you like to start by telling everybody a little bit about your children and your experience with the service so far?
So my name is Maureen O'Sullivan. I have 3 children, a 13-year-old, a 10 soon to be 11, or an 11-year-old and a 10 soon to be 11-year-old. So my 11-year-old is Rory, and he was diagnosed with autism spectrum disorder when he was 3 years and 3 months. And then I have Avine, who is 10, and she was diagnosed with autism spectrum disorder when she was 2.5, nearly 3 years old.
Okay.
Rory is verbal now, only started speaking when he was a toddler, and then lost his words, and then started speaking when he was 6 years old. And Avine is 10, and she's non-verbal and uses pecks and love and any kind of communication to get whatever she wants, whenever she wants.
Lovely. So great at using like the more total communication.
Absolutely, yeah.
Fantastic, lovely. Okay. I suppose maybe starting with Rory, as that was your first time.
Yeah, so Rory, they were both assessed quite differently. So Rory was seen individually by individual professionals. So he was seen by speech and language, occupational therapy, and psychology. And Avine's approach, which was much more of a multidisciplinary team approach, where they came together. I probably, in hindsight, found Avine's easier, but I don't know if that's because I had gone through it already, or because I didn't have a wait for everybody. Everybody was in that room together, and everybody sat together and worked as a team to assess her in a much more, I felt, a much more friendlier environment, as in it was much more kind of play orientated. And I suppose maybe because I didn't have that wait for each individual, that it didn't really feel like it was as long a process. I found the whole process quite upsetting, really, because even though you know that there's something wrong with your child, for somebody to say it out loud or to see it in black and white, and I suppose looking now on this whole neurodiverse approach and how you word and the affirmative approach that you're going to start using, I think it's much more of a positive approach. I find reading Rory and Avine's assessments extremely upsetting. I never go to them unless I have to fish them out. Yeah. I never look at them for any feedback for myself. I find them really, really upsetting. I think to look at it in black and white that your child is deficit or is different or does not meet the expectations of a 3-year-old of the same age is it's soul destroying to read, and to read that now, even years down the line, is really, I never touch it. I never go near it unless I absolutely have to. I never take those assessments out.
Yeah, I understand. So it's fair then to say, Maureen, that one of the main things you find the hardest about the reports is the language that's used within the report when describing Avine and
like I would never read that now unless I have to go fishing for it for, a report for a school or whatever. I wouldn't look at it at all.
And do you feel, or do you think that if the report was written using kind of our more neuroaffirmative language, so validating the autistic experience or recognizing autism as being a different but equally valid neurotype,
and if it was just simple wording on it that I could look at it and go, look at all the positive things, look at the good things. Okay, things are different and things are a struggle, and yes, we have to work around it, but these are the ways we can do that. Or, okay, my child doesn't speak, however, her communication through non-verbal language is fantastic. Something like that would make me think, okay, so she can't speak, but oh my God, she's really good at communicating what she wants without saying one single word. Not one, like that in itself is pretty amazing, to be fair.
It's really good to hear you say that, and that is exactly the direction that we're trying to move in, and that's exactly the purpose of this. So do you notice a difference in kind of the neuroaffirmative piece now?
I suppose with the gap because of the pandemic, we haven't had much interaction with a lot of professionals, but certainly from a speech and language point of view, absolutely, yes. I can see it's all about a total communication approach rather than, pushing Avine towards what's this, what's that, and embracing the ability that she has with her communication, rather than forcing her to be in one group of cohort people.
Yeah.
So, and then as well, for say like the likes of Rory would be very anxious, albeit he's verbal, he often doesn't understand a lot of how he feels, and would stim a lot to self-regulate. And whereas before, early on in his in our autistic experience, I suppose I would have kind of maybe said, oh no, shush now, and don't do that, and be quiet, because that's not acceptable in the outside world to be spinning or jumping up and down. Whereas now, if he needs to do that, he can do that, and I'm okay with it. And if anybody looks at him, rather than me go shush, I'll just say, oh, I'm sorry if this is upsetting you, but he has to do this because it regulates him.
Exactly. So nice to hear you saying it like that, and your understanding of it.
So yeah, I suppose I had that vision in my head of Rain Man, and it would be a certain way, or or that that they wouldn't live a fulfilled neurotypical life because of their different abilities and their different needs. But I suppose as life and probably as they have grown, I have grown with them and understood that just because they have certain ways of doing things, it doesn't make it wrong. Like, I mean, who are we to say that we're doing everything right?
Yeah.
Like we take this high moral stand, like we do everything right, and that the neurotypical world have it down to a T, and that everybody should follow us. Well, do you know what? Maybe, just maybe, if we stepped into their world a little bit more, we might be that little bit kinder than what we are. Because my son is so kind, and my daughter is so kind. She just sees the world as she sees it, and who are we to say that they're wrong and that we're right?
Can you tell me what you feel has been the most helpful thing that the service has done for you and your children?
I suppose I've done quite a lot of any education that they've given for parents, like little courses like the Hannon course, or any kind. I kind of really threw myself into it because I felt the only way I could help my children was to understand the world that they were in. So the services that whenever there was anything in the way of educating parents, I suppose they always contacted me, and I sort of threw myself into anything that I could that was offered to me, which definitely helped me understand that. Again, I'm going to go back to the analogy of, they're not broken. I don't need to fix them. I need to understand them. And I suppose maybe that's probably the most powerful thing that I've learned through working with the professionals in HSE, that, well, why are you trying to do that, Maureen? Are you trying to do that because that fits around your world, or are you, do you want to change him, or, so I suppose it kind of goes back to that as well. My children are not broken. They don't need to be fixed by anybody. And I find sometimes outside of our little bubble that is the case. And I've had to say that prior to now, to different communities outside of here, and say, like, why do you feel the need to stop that? If he needs to stim, then let him stim, it's fine. Or if she needs to bounce up and down to regulate herself, it's okay. I suppose we would have been heavily in the need of speech and language, more so than psychology in the early years. So from that point of view, I suppose that whole total approach of communication was really, really important to us as a family, that it didn't matter if the words weren't there, that so long as we had some form of communication, that was the important thing.
Maureen, can I ask, what advice would you give to any of the professionals watching today who are supporting autistic children and their families, or is there any piece of advice that you feel like you would like to share?
I think validate the parents as well. Like, we know our children so well. We really do know our children. We may not understand them initially, and we may not understand the whole autistic approach and stuff, but we know our children so well. Like, I was the first person that felt my baby's move. I was the first person to see my baby breathe. I was the first person to see my baby walk, talk, cry, feed, everything. So I know my child so well. I know the difference in his cry and her cry, in the difference in their stims and what their stims mean to them, and when they're high, when they're low, when they're level. So, like, I suppose validate what we have to say. I have to say I have felt validated before. Just sometimes I feel that, yes, you professionally, you know it 100%, and you can teach us professionally everything, but we know our children so well.
Hello, everybody. And wow, that was just fantastic. Thank you so much for that, Maureen. And now it's time to delve deeper into some of the issues that were discussed, and some of the issues that have been highlighted by our audience with the questions and answers. Thank you so much. So we're joined by our panelists, along with Maeve Kavanagh and Jessica K. Doyle for the question and answer. And here's Karen Coleman, and oh my goodness, everybody is joined now, and Davida Hartman. So the whole gang is here, and welcome everybody. So we're going to start. Jessica, if you don't mind, I have a question for you. An attendee asks, I have met so many autistic children who really want to fit in and have friends. That's their goal. Without promoting masking, which has been the traditional way of trying to achieve this, is it possible to do it without really educating neurotypical children and teaching them about how autistic children like to communicate?
I think the answer is kind of no, that it's not possible without really educating neurotypical children and teaching them, because I think it's important that it's like a joint effort, that both autistic children learn about neurotypical ways without actually becoming that, and neurotypical children learn about autistic ways without becoming that. I suppose it goes back to the double empathy problem. We struggle to understand and connect with things that are or ways that are different, and we both need to learn what the way is like without. It shouldn't be all about teaching the autistic child how the neurotypical child interacts. It needs to be a joint, both of them learning about this is the way, this is what they might mean by this, while you might mean this. And that was a bad example, but it needs to be a joint effort of both of them coming together to learn just about difference and kind of make friends that way. I think that answers the question.
Fantastic. Does anybody else want to join in there as well before we move on? Thank you, Jessica. That was fantastic. Okay. So this is a really interesting question that came in on one of our other channels. How have CENOs responded to your new diagnostic reports? This is to the team and Carla Kilkenny.
Sorry, we're just trying to unmute ourselves there. I'm hoping you can hear us as we're all backing away from the laptop. Really positively, to be honest. I contacted our local CENO in advance of this webinar just to kind of get her feedback and see how she's received her new reports. And her perspective on it was really, really positive. And she's given me permission to represent her viewpoint tonight, which was that as a CENO, she looks for three things in a report. She looks for the identification of autism in line with either DSM or ICD, which we continue to do. Evidence of complexity of needs, which we kind of reframe as the areas where an autistic child or young person requires support. So their support needs, which we continue to outline in reports. And then the reasons why an autistic child or an autistic young person might require an autism class. And her sense of that was that there was no reason that those three criteria couldn't be outlined in a report that's framed using the social model of disability. And from her perspective, is a much more child-centered way of working. So it's really great to hear that not all services and agencies are operating under this particular framework, but the NCSC, our local CENO, is happy for us to continue to do so. And I think we've been really lucky because we've always maintained a really good relationship with our senior. We've been really lucky in the working relationship that we've had with her for years, and we maintain open communication, and she will link with us if she wants any further information in relation to reports and so on. But also our previous reports, even kind of working in the older style, we had never used terms like levels or functioning. So in that way, it wasn't a phenomenal departure in terms of what the NCSE will look for. But certainly at a local level, they're being well received by the NCSE, and we're not running into any difficulties in relation to that.
Yeah, and I think, can I just ask, I think for any teams that's a really good, I mean, you guys are lucky that you have a really good relationship with your CNO, but I think for other teams, it's well worth, if you're going to be changing reports in any way like that, it is well worth picking up the phone to your CNO and trying to develop a relationship like that. And, you know, talking to them before the reports even come in, talking to them about, you know, this is how we're going to be framing reports, and you know, all those things that you just talked about. So it's well worth doing that before you know, send in the reports to them, because that's my experience as well. That once you talk to the CNO and explain things, you know, usually they're you know, for the most part, it's great.
Fantastic. We actually have a similar or follow-on question, really. Does this way of working impact on accessing supports such as the DCA?
Yeah, a lot of work needs to be done in that area. I suppose I'm a social worker on the team, and I'll be out at families, and I'll be helping families apply for DCA. And they're really using the medical model, and that's what we're trying not to use now. And so it's really a deficit approach. So when a family, or when I was out with family previously, I'd be saying, to be perfectly honest with you, you know, tell me the worst day in order to get that support. So hopefully with further communication with the Department of Social Welfare and other agencies, that we can change that. And, you know, that if a person, or if a young person has a diagnosis, that should be just accepted. They shouldn't need a full report. They should accept a letter from a professional, and that a family shouldn't have to beg for social welfare payment. You know, a human rights dignity piece is there, and they shouldn't have to appeal it. They shouldn't have to go through all of those processes to get something that should be any child's if they need it.
Fantastic. Thank you.
I just add something really briefly to that, just to echo what Brian said there. I think it's really traumatic for families having to go through that process when they've had such a warm, positive, affirmative experience in terms of the assessment piece that happens in a neuroaffirmative approach. And then you're almost having to counsel them through what you know is going to be traumatic for them. And listening to Maureen talking about what it was like for her, even just reading the previous reports that she would have received and how difficult that was. When you're asking, you've worked so hard to support families to reframe their understanding of their child, or to learn, you know, an affirmative approach in understanding their child, and then you're almost having to undo all of that again by going back to this DCA application. And yet it's such an important support for people that they really, really need to get.
And many of our families stop then applying because they feel, you know, that they're begging. And that's where the dignity piece is. So we shouldn't have our parents coming in and to feel that they have to leave their dignity at the door to apply for something. So I feel really strongly about that, and so does the rest of the team here. So hopefully, you know, through conversations with different agencies, we can change that to be really child-centered.
Fantastic. Another question, and what are your thoughts on the practice of carrying out cognitive assessments with autistic children as part of the assessment process? They often don't do well in these assessments, and it doesn't feel like a true reflection of their abilities. Who would like to take this one?
Yeah, so Tara, I got stung with two questions. So tonight's winner, I think. I think even before we made this conscious move towards a neuroaffirmative paradigm, we were seeing that there were really, really big issues with using cognitive assessments with a neurodivergent population. Standardization criteria is really only applied to a neurotypical population. And what we were finding was that when we were doing cognitive assessments, particularly with autistic children and young people, that everything had to be accompanied with a really long and lengthy caveat that this is likely not a true representation of a child's abilities. So, I mean, we have been for a long time questioning what role they play in our work. And so we've been looking at alternative sources of information. So looking at adaptive measures, looking at information from parents, from preschool, developmental observations, linking with other clinicians, really to get a more thorough sense of what a child needs in a school setting. So moving beyond cognitive scores as being kind of a very rudimentary kind of outline of where a child's abilities lie. And it's interesting, the ICD-11, I think, is actually drawing reference to that, which is out soon. And there's been an article released in the last couple of months looking at behavioural indicators in relation to cognitive functioning. And so suggesting that standardised cognitive assessments don't necessarily always need to be used, that we've other sources of information that we can rely on. And I think that's a positive direction that we move towards.
Yeah, and can I just add, I completely agree with everything that you've just said. And unfortunately, in Dublin, there's a lot of, to access certain services, particularly, it may be in other parts of the country as well, but I certainly know that in Dublin, unfortunately, there has to be a cognitive assessment often. And again, that's a systems issue because they're not very helpful, and there is the big long caveat at the start, and often they need to be reviewed and redone anyway years later. But yeah, unfortunately, it's still part of the system that, I suppose I'm saying that for anyone who's wondering, well, why did that, why was there a cognitive assessment done in my assessment, for example, that is the reason why sometimes, particularly Dublin, for Dublin services. I'm sure it's elsewhere as well, but Dublin seems to be particularly bad for that.
This is a great one. How were you able to get the whole team comfortable in switching from behavioral to neuro-affirming practices?
I suppose I haven't come, I suppose any of the members of the team that I would liaise with, everyone is very keen to learn more about the neuroaffirmative paradigm. They would hear us talking even over lunch, we did this training last night, where, something really resonated with us. Or, when we're doing joint pieces of joint working, we might refer back to training and think, I wonder, is this what's going on here for this particular young person? So I don't think we can claim to have done that, and that we have, got the whole team on board. Ourselves, we're very early on in that journey, I feel, where we are just learning more about what is neuroaffirmative practice, what does that look like, how can we use that, within our own practice. And I suppose that's part of that, that process of spreading the word, I suppose, is, engaging in this webinar. Our team is aware that we're doing this tonight, and we hope that some will be able to watch live, if not the recorded version. So I suppose it is very much a work in progress as well.
But we belong to a very positive team.
We're very
lucky in that regard. So they're very open to it. And everybody has been reflective upon any of the training that we've taken part in, and they've asked questions, and
looking for more
so it's been great. We're very, very lucky to be part of this team.
And other members of the team have completed additional training in this area beyond just, particularly the Inside Autism. Kieran Rowe's training, I think, was a very popular training that a number of team members attended. So there's an appetite for change, really, anyway.
And as we've said, we've recently just progressed just the last 2 weeks ago, 2 weeks, and so this is going to be very much part of it. So we hope that it's going to be a positive future for the team.
Yeah. And I think as well the fact that individual heads of disciplines support us, or new CDNM support us, it really creates that atmosphere for change that everyone has brought into, which is great.
Thank you so much. And Davida and Maeve, you both have experience of that shift as well in the adult autism practice and childversity. Would you like to contribute something to that piece? Throwing it.
I suppose, it's funny because, I mean, like we said in the first webinar, it's all very new. It's quite new to us as well. It's been a change process over the really quickly over the last year, let's say, and slowly before that, but really it's been a very rapid change within the last year. So you know, we're still learning and growing too. But certainly anyone, I think, you know, there's a huge appetite for change in any of the teams. So for example, in the children's clinic, you know, we've started taking on more and more of these neurodiversity affirmative approaches. And but even outside of that, with any professionals that I meet, if they're coming to it new, or say new team members, for example, in the adult autism practice or the children's clinic, and you know, they might still be using ASD or maybe come from more behaviorist approaches or anything like that. But very, I mean, almost immediately when you're showing them the resources to watch and showing them the videos from the actually autistic people and showing them our language guide that Jessica did, you know, I haven't yet had somebody go, oh no, I don't like that. You know, every single person that has spoken has come on board and thought, you know, really has embraced it and liked it and put things into practice. Would you find that, Maeve?
Yeah, definitely. I think as well, you know, it's a change process, and you know, for us, it's been over the last maybe 18 months or so that we've really embraced and learned, and we still have so much more to learn. That's continuing. And I think, you know, for people who are newly coming to this or starting to think about, well, what are the pieces that they can work on in terms of change, it is about those small ripples of change and changing certain aspects, working on, you know, it might be language, it might be how you write a report, it might be, you know, various different things like that, or how you speak with parents or attending a training. But it's all of those little things that add up and that bring you to this place of a different understanding. And I still, you know, every time I work with an autistic colleague, I learn something new from the perspectives that you share. And it never, you know, that learning and that change process continues. But I also think that there's a huge shift in terms of what parents and families are looking for and wanting, and with I guess I think that was really evident in what Maureen described earlier. You know, and I think working with them differently in terms of being more collaborative in our approach, and you know, parents being part of the team around the expertise on their child, that's massive. And really important that we shift our thinking away from us being experts. But that there's shared expertise, you know, so there's huge amounts of change to happen.
And I mean, the reflective piece, you know, as a psychologist, it's actually actually almost a relief that you know, you don't have to take this expert position, that, you know, it is this collaborative process, like Maeve was saying, between you and the parent, or you and the older child and the parent. And and we don't have all the answers, and that does take away some of the pressure that I know particularly recently diagnosed psychologists or any of the team members who are doing autism diagnostic pieces can feel around needing to make the call.
Yeah, and I think when you're working with younger children who can't articulate or communicate what their inner experience is, you've got to work collaboratively with parents who are the experts on their child and their needs. You know, until that child is at a point in their development where they can communicate what their experience is, because I think you know, and I think we're learning this in Childversity at the moment, where we're working with families of very young children where it isn't, you know, hugely clear that autism from a purely observational perspective might be what's there, but yet when you listen and you engage with parents about what they're noticing, and you know, work with them in a different way, you can work things out and figure out the ways of you know, what makes the most sense. So that collaboration and that piece is huge.
Fantastic. Thank you so much. And I think as I suppose as autistic psychologists and professionals, it's so heartening for us to see the change and the neuroaffirmative change process happening in individual teams across the country and across the world. It really is, and it's making it a lot safer for professionals who are autistic themselves to feel welcomed and to feel safe to come out.
Because of course there are autistic psychologists making autism diagnosis and identification. There are a great many, But,
exactly.
but there is, you know, there is still, and we would have tried really hard. So you'll see, you know, this webinar in particular was quite neurotypical heavy, particularly compared to our first one. But, you know, we're really working towards trying to you know, put forward the voice of autistic psychologists, but there's still so much stigma within, you know, and that's the whole point. That's one of the reasons why we're putting on these webinars, is to try to, you know, break down that stigma. But I think there's a huge sea change there. I think in a year or two, it's going to look very different. Don't you think, Tara? Like, even in terms of psychotherapists, like when we, you know, a year ago when we started this, I didn't, you know, I had maybe 1 or 2 autistic psychotherapists to refer people to, you know, children who maybe needed more in-depth psychotherapy, for example, after an assessment. And now I have a long list of people that I'm really happy to recommend to, who are autistic and psychotherapists and out on, you know, fully out, embracing their
absolutely. And now in Thriving Autistic, we started a year ago, just 1 person, and now there's 21. So 21 autistic psychologists, psychotherapists, speech and language therapists, occupational therapists, you know, across the board. So
yeah,
it's so exciting to see.
Yeah, it is.
Jessica, I don't want to put you on the spot, but if you want to chime in, do.
It is very exciting. Like, before I came to work with the adult autism practice and with Thriving Autistic as well, I would have told everyone I'm autistic because I like to do that, because I like being autistic, but professionally it would have been slightly terrifying. But now I feel a lot more like it's now okay to say it. It's like seen as can be, being autistic can be really useful to working in autism.
Yeah.
And it's so wonderful to, hopefully that's going to spread into everywhere. It'd be wonderful. And I think it is. So it's good.
Yeah, I think so too.
Thanks, Jessica. Okay, so I have another really interesting question about parents. How do you help on your team? How are you helping parents to shift to the neurodiversity model?
I'm going to answer that, and I don't know if it's any different to what David and Maeve have already talked about. I suppose from the very onset, when we make contact with parents and families, we would take a very child and family-centered approach. It's the language that we use, it's the resources that we signpost to, and I suppose as well, it's about the collaborative piece, that we're not coming in as experts saying that we're going, you know, that this is going to work for definite, or you know, that we have all the answers, but rather that we are going to try support and to figure out what exactly are the support needs for this young person. And I have to say, we had a quick chat about this, but I think across the board, most parents are just so welcoming of a neuroaffirmative approach, and they're so happy to have this positive experience and to have these positive insights, that you just want to learn more about it. They just want the best supports, I suppose, for their child.
Yeah, we'd find that in the children's clinic as well. You know, I don't think there has been any really, you know, once it's explained in the way we've explained it today, parents are really on board and delighted, and yeah, really positive about it as well.
And it's relief for some parents as well, because sometimes they'll hear, you know, negatives from other people, and when they come into our service and it's positive and the people that they meet are positive, it's a relief, and they go, oh yeah, but there's nothing changed about your son or daughter. You know, we're here to embrace that. So they're delighted with that approach.
Yeah. I mean, they will sometimes say, no, I don't, you know, I want to say, you know, I don't like saying autistic, for example. That would be one thing, that, particularly when they first come in, you know, I don't want to call him autistic because I don't want that label, or, you know, he's a person, you know, and all of that. But, you know, over time, my experience is, you know, that's their journey to make, and you provide them with all the information. And my experience is that over time, they also then embrace identity first language eventually. But even if they don't embrace the identity first language, they still will embrace everything else. That seems to be the one, you know, that's still hard for people at the start. Some people, not everybody. I have to say, you're a great advertisement for Carlo Kilkenny team at the moment. Seriously. The HSC are going to be delighted with you. This is really positive, like, you know, it's just brilliant. It's great to see all this.
Well, it's a good team, so we're looking that way. So
just to add on to that, B-Star, I think for me anyway, I don't know if anyone else found or says being nervous talking with parents who we had known under the older model, the older approach, and where we had used terms like your child has ASD, and then, you know, meeting them again for whatever reason, and then this shift in language, the shift in understanding. I found that something I was really nervous about, that I was going to say, well, actually, you know, the way I explained this and this is what I said was a really good way of understanding it or describing. That's now changed, and I thought that was going to be quite poorly received, or parents would say, well, why are you changing your mind? And actually people just say, okay, that's something new you've taken on, and that's a change in the understanding, and they're very, very happy. There's been no opposition. I don't know if you've had it, you know, but that was certainly something I was really, really nervous about, and thought that might cause some difficulties, and the opposite has been the case. I think parents appreciate when you say, this is what we thought, but actually we've learned this now, and they appreciate that you can go back and say, that's what we thought, but we've learned more, and we feel a bit more secure in using this kind of language now.
I think as well.
No, Maeve, sorry, you wanted to jump in?
Just to say, I think as well for many parents, there's a sense of relief around it, that there's, you know, because what you're saying is, you know, there isn't anything that's damaged or broken or that needs fixing or that needs changing. You're talking about acceptance and validating and understanding, and I think that's a lot easier for a lot of parents to relate to. It resonates with them because they, I think, intuitively never thought there was something wrong with their child. Most, but for quite often, that's been my experience. But there's a sense of almost relief then that you know, it's like, yes, this is, you know, you're seeing my child through, you know, how I see them. Not always, I'm obviously very generalizing there, but I think that can often be an experience for a lot of people, that there's a sense of relief that you're approaching it in that way.
That's fantastic, Maeve. Thank you so much. You know what, we could go on, I'd say, for another hour, but we don't have the time, and we promised everyone we'll keep to time tonight. I'm going to ask one last question, and wonderful comment and a question. Wonderful presentation. Thank you all. This approach will impact the mental health outcomes of the kids lucky enough to attend your service. Are you planning to capture this data? So have you got any research planned, or would you be open to doing something around that for us all, so we can all avail of this wonderful work that you're doing?
I think one of our first steps, one of our kind of, you know, plans for the future, near future, would be to get feedback from, you know, the families that are going through the service. I think that's a really important, that's our most important piece of data, really, would be to see how they found it and what ways can we improve, and how can we be more accommodating of, you know, the whole family's communication preferences as well. I think that's our first first step next.
And I think it's a really good, sorry, go on.
No, she just said
we're only beginning.
Okay. No, I was going to say, I think that's a really good point, because I think, you know, a lot of people will look for, not everybody, but a lot of people will look for, well, where's the data, you know, where's the research data to show that this actually has a positive effect on families? We know it does, because we're seeing it on the ground. It's so clear to us. And there is so much research around the negative effects of masking and all of those kind of things. But I suppose, that's where, you know, what would be really good, I agree. I mean, it would be amazing if this was captured. Like in the adult autism practice, we're looking into starting to, at some stage when we finish the book, capturing some of the data there around neuroaffirmative adult autism assessments. But yeah, it would be amazing if a similar thing happened with child assessments.
Yeah, we look into it.
Yeah.
We can
pass you on.
Thank you all so much. We have lots more questions, and I wish we had time to get through them all, but we just don't. So we've heard a selection of some of the wonderful questions and comments tonight. Thank you to the team. Thank you all so much for sharing your experience with us, and allowing us a glimpse into this change process as it's happening. When we finish the webinar tonight, there will be a survey, and we would encourage everybody to please give us your feedback. Pop in there any questions that you have, and we will do our best to contact you and get back to you if you want to put your email address in. And please, just also to remind you that we have Our next event will be next Wednesday evening, and you can book online on the PSI website for it. And then the following Wednesday week will be the final event in the series. So lots more time for lots more questions. But if you have specific questions for this team or anybody on this panel, please add that into our survey, which will be at the end. So again, thank you so much to all of the contributors this evening and all our panelists. We'll do our best to get the recording of the event online as soon as possible. And yes, next week we'll be hearing from some of the team members based out of Lucena, and also a senior psychologist in primary care as they discuss the change process that they're initiating within their team. So thank you again. If you require CPD points for tonight, please email autism@psychologicalsociety.ie. Take care, everybody. Thank you.
Thanks so much, everyone.
Bye.
Good night.